Good evening, everyone, and welcome to the webinar on the theme Innovations in Immunotherapy Advancing Care in SCLC. It gives me great pleasure to introduce our program director, Dr. Ullas Batra, co-director of Medical Oncology, Chief of Thoracic Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. So will be joining us shortly. It gives me great pleasure to invite our first speaker, Dr. M.V. Chandrakanth, Medical Oncologist, Academic Head, Department of Medical Oncology, Narayana Hospital and R.N. Tagore Hospital, Kolkata, to give a talk on the topic Current Treatment Options in Management of SCLC. Over to you, sir.
Good evening, all of you. So I would thank the organizers for this opportunity. Uh, I would thank Avina Creations and also AstraZeneca for providing this platform and the opportunity. So, well, in coming 15 minutes, I will be taking you through the way the management of small cell lung cancer treatment has evolved over a period of time. Next. Well, if you look into lung cancers, non-small cell lung cancer is 85%, 15% is small cell lung cancer, and the median age is 60 years. And half of the small cell lung cancers develop brain mets at some point of time, and more than 90% of them have a history of smoking. Next. So if you look into small cell lung cancer, around two-thirds of them are extensive stage and one-third are limited stage. And even though the incidence of small cell lung cancer is low, the conversion to mortality, the recurrence rates are significantly higher. Therefore, small cell lung cancer is a real concerning disease and it's an unmet need to improve outcomes in this space. Next. This is some Indian data again suggesting that uh, the age is around fifth and sixth decade, and you can see the increase in incidence from 60 to 70 years, and 75 to 79 is where you have the highest incidence, and the median age at US is 69, whereas in Indians it is little younger. Next. Yes. So the moment we hear lung cancer, it's always about TNM staging. However, with small cell lung cancer, even today, we follow the veteran classification for lung cancer staging. So it is the veteran staging, the VALSG staging system is the one that we use for staging small cell lung cancer. Roughly, to understand how a VALSG staging system is, whether the disease is confined to an area that can be encompassed with a radiation port, that is limited stage. It may include a disease in the lung parenchyma or the regional nodal metastasis with or without pleural effusion. This is limited stage disease. It can include stage 1 to 3B. So remember, a mediastinal lymph node is also included in the limited stage disease. So around one-third of them are limited stage, whereas the one that is beyond this radiation portal is an extensive stage disease that compromises two-thirds of these patients. Next. Well, so we already saw that small cell usually presents in an extensive stage disease in almost two-thirds of them. And in India, the extensive stage is much more common than what you see in the West. Nearly 83.4% are with extensive stage disease, and 69% of them have more than one site of metastasis. Next. This is how you choose treatment for limited stage and extensive stage. A very small subset of small cells still become eligible for surgery very early stage. Otherwise, it's concurrent chemo radiation followed by prophylactic cranial irradiation and maybe an immunotherapy that we will going to discuss in the maintenance setting. Similarly, for extensive stage, there you would combine immunotherapy along with chemotherapy, and then you would continue immunotherapy maintenance. You may consider PCI and consolidation of the thoracic artery in those patients who have got a good response. Next, let's go to the current standard of care in extensive stage small cell lung cancer. Next. Yeah, if you look into the evolution of extensive stage small cell lung cancer, so platinum etoposide is the standard of care, and then you had topotecan coming in, and then carboplatin also pitched in, and then you can see the PD-1 inhibitors were there initially, and then they are withdrawn. Both pembrolizumab and nivolumab were withdrawn. However, PD-L1 inhibitors are the winners in extensive stage small cell lung cancer. You would see both atezolizumab and durvalumab being approved in combination with platinum and etoposide. Just note that atezo was with carbo, whereas durva was with both carbo and cis. So this is how you would see, and you are seeing some new molecules like lurbinectidine that is going to be there. So this is how the evolution of extensive stage small cell lung cancer is, where you would use chemo immuno combination. Whereas in limited stage, you will use concurrent chemo radiation followed by immunotherapy maintenance. Next. Well, immunotherapy plus chemo is the preferred first line treatment for extensive stage small cell lung cancer. As I discussed before, it is the PD-L1 inhibitors that are the winners. And you can see both Durva and Atezo there. Durva is with cis or carbo, whereas Atezo is only with carbo. Currently, there are no biomarkers to select which patients are eligible for IO. So PDL1 is not a great marker in small cell lung cancer space. Next. Right. So how do we approach the treatment of extensive stage small cell lung cancer? You use chemo immuno combination, and then you would use immunotherapy maintenance. And then depending on the platinum free interval, you would decide on the subsequent line treatment. You can see topotecan, irinotecan, lurbinectidine being there in the subsequent lines. Next. Right. So this is what we were just addressing, the immunotherapy agents which got approved and then withdrawn. However, in the first line management, front line Durva and Atezo. The Campaign study in 2019 and the IM Power 133 in 2018 both have been approved chemo immunotherapy combinations in extensive stage. Next. Right. So this is Durva, Atezo, and the combination. The number of cycles you would go is up to 4 to 6 cycles. PCI and radiation at physician's discretion to prevent and treat brain mets respectively. And then you can see once there is a good response, you would continue immunotherapy maintenance. And depending on the platinum free interval, you would decide on the subsequent line therapy. So NCCN guidelines say 6 months as a refractory or resistant disease. I mean, that is the mark, whereas ESMO says 3 months. Anyways, it's more of a clinical decision. 3 to 6 months is what the duration is for platinum sensitivity. Okay, next. So now coming on to the Caspian study. This is Durva in combination with platinum etoposide. So you can see the three arms. Let us focus on the first and the third arm. Durva EP followed by Durva maintenance. Just focus on the doses of Durva. It's 1500 milligram 3 weekly for the first 4 cycles, and then 4 weekly until disease progression. And there was an optional PCI. In the arm C, you have EP for up to 6 cycles. The choice of cis and carbo was allowed. Both of them were eligible in contrast to atezo, where it was only carbo. The primary endpoint is overall survival. The secondary endpoints are progression-free survival, response rates, quality of life, and then OS at 18 months, safety and tolerability. Next. Yeah. So it is a positive trial. Durva plus etoposide platinum is the first and the only approved IO to demonstrate a statistically significant and sustained improvement in overall survival versus EP at 1 year, 2 year, and 3 years. This is the 3 year overall survival in the Caspian trial. And you can see what is not, it is not just the median that you would look into, it is the tail of the curves. It is the percentage of patients being alive at 3 years. It's 5.8 versus 17.6. And also, if you look into the median, the hazard ratio is 0.7, it's 12.9 versus 10.5. So it is not only the median, but also the tail of the curve, and the long-term survivors is what you would focus with immunotherapy combinations. Next. This is the IM power 133 data. So you would still see the separation of curves, impressive still. The hazard ratio is 0.76, 12.3, and 10.3. So in IM power, it was only carboplatin that they used. So OS improvements were sustained with 22.9 months of median follow-up. Next. So the key phase 3 IO trials for first line Caspian and IM power 133. So we already saw the treatment arms. The TRIME is not being discussed here. The overall survival was significantly improved when you had chemo-immuno combination, and the Pembro and the Nivo, they did not meet the threshold, the significant threshold. Therefore, the negative trials. Next. Now coming on to limited stage small cell lung cancer. Next. Right. So we saw that limited stage is around 1/3 globally, whereas with us it's around 15%. It's lesser than the global percentages in the Indian setting. And you can see the pathway of how we diagnose. We do a PET CT. We also we stage based on the veteran classification, and we do an MRI brain, and then we would consider concurrent chemo radiation in all good performance status patients. And in those who are not eligible for combined modality therapy, we would consider sequential. And a very select subgroup, we would consider surgical resection. So this is how the pathway of presentation and the standard of care in the present day. Next. So even though we have a limited stage disease in small cell lung cancer, there is a high unmet need. Why the unmet need is high? Because all of them invariably relapse. Although some patients with limited stage have long-term survival, the overall cure rate remains very low. Despite having an initial sensitivity to chemoradiation, majority of patients relapse within months of initial therapy. Nearly 30% of patients with limited stage lung cancer are alive at 5 years. The 5-year overall survival is around 16 to 34%. So in our real world, we have seen that the percentages are far less. Invariably, almost everyone relapses over a period of time. So around 2 years is a median overall survival if you have a limited stage lung cancer, if we are not giving consolidation immunotherapy. Next. So what are the advances that we have seen? So we have seen giving radiation like once daily to twice daily, the hyperfractionation that has been shown to be improving survival. The problem is toxicity and translating this to practice. Esophagitis has been really concerning in those patients where we give more frequent radiation. So therefore, there has been an unmet need, a non-toxic way of improving survival even in the limited stage setting. Next. These are the NCCN guidelines for limited stage. Just focus on good performance status. You would consider concurrent chemoradiation. If the performance status is poor, you would consider sequential. And then if you have got a good response in the limited stage, you would consider durvalumab as adjuvant, and an optional PCI is there. So you can opt for a PCI or an MRI surveillance based on the ADRIATIC study. So just focus on cisplatin being there, the doses of cisplatin and etoposide for 3 days. So durvalumab is the only consolidation therapy that we have for which we have a positive result in the limited stage small cell lung cancer in those patients who have response to concurrent chemoradiation. Next. Right. So we've looked quickly into the looking quickly into the summary. For extensive stage, chemo-immunotherapy combination, both Durva and Atizo are approved. They have got positive trials in terms of overall survival. We did not, but after the Adriatic, what we can see is concurrent chemoradiation. After that, giving consolidation, durvalumab improves outcomes. PCI is recommended. However, if someone opts for MRI surveillance, it is reasonable. Next. Right. So I think again, I would thank all of you for your patient hearing, and I would thank the organizers for this opportunity, and looking forward for further presentations and for a panel discussion. Thank you.
Thank you so much, sir. I would now like to invite our next speaker, Dr. Sayan Paul, Senior Consultant Radiation Oncologist, Apollo Cancer Center, Kolkata, to give a talk on the topic Evolving Role of Radiation Therapy in SCLC. Over to you, sir.
Good evening, and thanks to AstraZeneca and Dr. Batra for this opportunity. So, my previous speaker, Dr. Chandrakanth, has almost said almost everything about the management of small cell lung cancer. I will just do a quick review of the role of radiation therapy in the management of small cell cancer. Can I have my slide, please? Can you share the slide?
Yes, sir.
Yeah. So, radiation therapy is an integral part of management of small cell lung cancer, and the trials are quite old. As we know, already Dr. Chandrakanth has said the survival of small cell lung cancer, the results are dismal, not very encouraging. So, next slide, please. So, poor outcome. So, we need some newer therapies in small cell lung cancer. So, the overall survival in limited stage small cancer is like it has been like starred as flat for decades. Like the trials and the chemotherapy and radiation that has been used is being used for decades. So probably we need something new to improve the outcome of small cell lung cancer. Next slide, please. So what is the role of radiation therapy? Next. So radiation therapy has been introduced in the early 90s, and it has been seen that we use thoracic radiation therapy can actually improve the overall survival. Next slide, please. And also, if we use the prophylactic cranial radiation, we can also improve overall survival and recurrence in the brain. So this is a very old meta-analysis by Pioneer called 1992 meta-analysis, but it clearly shows that if we
Sir,
use
sorry to
radiation,
interrupt you. Sir, your voice is
yeah,
cracking, sir. It's not audible.
is it now it's okay? Hello, 1 minute.
Yes, sir.
Yeah, yeah. Is it okay now? Can you hear properly?
Yes, sir. Now it's audible clearly, sir.
Yeah, yeah, yeah. So the next slide, please. Yeah. So there has been many trials that whether to add radiation concurrently with chemotherapy. Chemotherapy, as Dr. Chandrakanth had already said, is cisplatin etoposide, which is the standard chemotherapy for limited stage small cell lung cancer, or sequential. And there has been studies, many studies, and it has been clearly shown that if we use the radiation as concurrent chemoradiation rather than using it sequentially, we can improve the outcome and overall survival, which is so radiation therapy that has been used in is the twice daily schedule. Next slide, please. So there has been to know what is the optimum timing of radiation, and there has been studies where radiation, if we do radiation within 9 weeks of starting chemotherapy, and versus of starting chemotherapy, the results are better if we can radiation as early as possible. So next, next. So, so there's media analysis that shows that concurrent therapy early within 30 days of start of chemotherapy, the results are better. So the earlier or short and this is a little newer one. So the only issue was that the radiation planning takes some time. So you start chemotherapy first, and probably you can add the radiation treatment with the second chemotherapy as concurrent chemoradiation. So if we use within 30 days after start of chemotherapy, the results are better. Slide, please. Next slide. So what is the current evidence for stage 1 to 3 SCLC? So CTRT is better than only chemotherapy, and early radiation, the previous one please. So early radiation, if we use it is using radiation late and concurrent chemoradiation, sequential radiation and chemotherapy. So what is the dose, optimal dose of radiation in small cell lung cancer? So conventionally, the BID dose is 40 gray in 30 fraction, twice daily fractionation. So that has been used with concurrent cisplatin and etoposide. So once daily fractionation has been shown inferior, there have been many trials. Initial trials were with the same dose, like 45 gray in 25 once daily fractionation, and it has been seen that the twice daily fractionation is better in terms of overall survival. Next slide, please. But this CONVERT trial, when they have used a little higher dose, this was actually a non-inferiority trial for limited stage small cancer. So it has been shown that if we use a little higher dose in once daily fractionation, then the outcomes are actually not different. So if we use a twice daily fractionation versus once daily fractionation, when the total dose is 66 day and the previous trial used 45 gray only. So if you increase the dose, so it is not non-inferior. So now both the dose schedules are standard of care, both higher dose with single daily fractionation and 45 day 30 fraction BID dose. Next slide, please. So people have, there have been many trials trying to increase the dose for once daily fractionation doses like 70 gray versus 45 gray in twice daily fractionation. And these has been shown that if we increase the dose, next slide please. If we increase the dose, so in limited stage, higher dose actually did not provide any additional survival benefit. So the previous trial was with 66 day 33 fraction. This is a 70 day. If we increase the dose, so actually you don't get any advantage over the standard dose fractionation. Next slide, please. So there is a meta-analysis of twice daily fractionation versus single daily fractionation. It's a mixed trial meta-analysis, and various dose schedule has been used. And this meta-analysis shows that if we use twice daily fractionation, it improves the OS and by 4 months. If we use it concurrently, twice daily fractionation. Next slide, please. So standard dose versus high dose. Now standard dose is 45 grain 30 fraction, and then the people have tried to increase the dose with 60 gray in 40 fraction BID dose. And if we use a little higher dose in twice daily fractionation, actually the outcome is a little better, but acute toxicity is little high. Next slide, please. So in 60 gray arm, the outcome though is a little better, but there is a little higher acute toxicity. Next slide, please. So these are actually the key trials for assessing the RT regimen. First one is the intergroup trial, which used BID fractionation versus the single dose fractionation. Then the convert trial, the non-inferiority trial, which shows if we increase the single daily dose fractionation, total dose, if we increase, it is actually similar. Then there are other CalGB trials with increasing the total dose, and that we have seen that we increase the single dose per day and increase the total dose, it's actually not giving any benefits. And there are some Chinese studies and newer studies which are increasing the total dose, but it is giving twice daily fractionation, which is shown to be a little beneficial. Next slide, please. So the current evidence is CTRT, then early radiation therapy, concurrent CTRT, and best survival results are still with early twice daily fractionation with concurrent chemotherapy. Next slide, please. So what about the prophylactic cranial radiation? So there have been many trials, and it has been seen that the prophylactic cranial radiation significantly improves the overall survival and also intracranial brain metastasis incidences. So PCI is actually now has been the standard of care before the MRI era for all patients who has responded with chemotherapy and concurrent chemoradiotherapy. And so for even in early stage and extensive stage, PCI has been used for decades. Next slide, please. So people have tried to increase the dose of PCI, but there is no benefit. So we use 25 gray in 10 fraction, which is the standard dose fractionation for prophylactic cranial radiation, and there has been no benefit of increasing the PCI dose. Next slide, please. So the current evidence is, as per the ESMO guidelines, so PCI improved survival 6% at 3 years. So PCI has been recommended in ESMO guidelines for stage 1 to 3 small cell lung cancer. Next slide, please. So There have been trials with immunotherapy already. Dr. Chandrakanth has said a few. So the durvalumab trial has been a positive trial, or the atezolizumab trial is a negative trial. There are other trials going on with pembrolizumab and sarsfluzimab. So this will be estimated results will be out in 2025. Next slide, please. So what is the clinical practice guideline of brain MRI surveillance? So ESMO says a regular brain MRI every 3 months in the first year and then every 6 months in patients who did not undergo PCI, whereas NCCN says that MRI or CT with contrast every 3 to 4 months during first year for all patients and then every 6 months as clinically indicated regardless of the PCI status. Next slide, please. So for extensive stage small cell cancer, this was limited stage. Next slide, please. So this is a landmark trial called CREST trial. So they have randomized patients for those patients who have responded to initial chemotherapy with thoracic RT or no thoracic RT. And it has been shown that, next slide, please. It has been shown that if you use thoracic RT to this group of patients, it increases the overall survival in the subgroup who has residual thoracic disease and who have received the thoracic radiation. So 1 year survival with thoracic RT is 32.5%, whereas without thoracic RT it is 25.9%. So next slide. So consolidation thoracic radiotherapy should be considered in selected patients who have responded to chemotherapy, residual thoracic disease and low bar extrathoracic disease. And the survival benefit has been reported in patients treated with radiotherapy after chemotherapy. Next slide, please. So what is the role of radiation in the era of immunotherapy? Next slide. So this is one trial in extensive stage small cell lung cancer, map plus chemotherapy and sequential thoracic radiotherapy as first-line therapy for extensive stage small cell lung cancer. And in this trial, they have combined this novel drug with concurrent radiation therapy and chemotherapy. Next slide, please. So it has shown that there is with thoracic radiotherapy and this novel drug, there is benefit of survival. This is the positive trial which shows improvement in survival probability. Next slide, please. So in summary, it is the first prospective phase 2 study to evaluate the combination of adabralumab plus chemotherapy and sequential thoracic RT in extensive stage. So this result indicates that this novel drug plus chemotherapy and sequential thoracic RT could improve the survival of patient of extensive stage small cell lung cancer. The median OS was 21.4 months, 1 year at 2 years. OS rate was 74.1% and 39.7%. The median PFS was 10.1 months. The safety profile was manageable and no new safety signals were observed compared to previous reports. The current study had several limitations. First, this trial was a single-arm phase 2 study design with no PD-1 or PD-L1 plus chemotherapy as a control arm. Next slide, please. What about the PCI? So guideline recommend considering PCI for patients with good performance status without cognitive impairment who are less than 75 years of age and responded to first-line chemotherapy plus minus radiotherapy. Although the two main studies to date evaluating the OS benefit of PCI in extensive stage have reported conflicting results. So the benefit of PCI in reducing the occurrence of brain metastasis have been reported by multiple studies. So close surveillance brain imaging, that is a brain MRI every 3 to 4 months, and every 6 months is advised regardless of patient's PCI status in order to monitor the brain metastasis. The role of PCI after immunotherapy and chemotherapy is not well defined because of paucity of data. The neurotoxicity of PCI is of concern. It is recommended that PCI is given at 25 grain 10 daily fractionations or a shorter course like 20 grain 5 fraction for selected patients with extensive stage small cell lung cancer. So this is actually the main two studies for PCI in extensive stage. One is URTC, one is Japanese study. When the URTC has shown there is a bit benefit of PCI, reduces the cumulative incidence of brain metastasis. But the Japanese studies says though it reduces the incidence, there is actually no improvement of 1 year overall survival. Next slide, please. So this was in brief, the overview of radiation therapy in small cell lung cancer. Thank you, and now I hand it over to the organization.
Thank you so much, sir. I would like to invite our program director, Dr. Ullas Batra, to introduce and invite our international speaker. Over to you, sir.
Okay. Okay. Good evening, everyone. And we welcome Dr. Noemi Reguart. If I have pronounced your name right, I may pronounce your name. I may not pronounce your name right, but I think anybody who has even a slightest bit of interest in thoracic oncology knows that you don't have a recognition. You don't you don't deserve a recognition. You are Noemi Reguart. That's it. So just for the uninitiated, Dr. Noemi Reguart is a consultant oncologist at the Department of Medical Oncology at Barcelona. She's the coordinator of the thoracic oncology at the hospital clinic. She focuses very much on lung cancer, a fantastic speaker. And I have heard her talks in ESMO and ELCC, and always, the audience, the hall will be full of audience when we have. She's a group of, she's in ESMO, she's in ES-SCLC, she's in board of director of the Spanish lung cancer group. And it's a pleasure to get you here, ma'am, and looking forward to learning from you. Over to you.
That was a very nice introduction. Thank you so much, Elias. So are you seeing the whole screen right now?
We can see it, ma'am, now.
Is it the full screen mode?
Yes, it is.
Okay, so that's great. So thank you so much again for this nice introduction. It's a pleasure to be here today with you in this AstraZeneca activity. And I don't want to repeat myself on the previous speakers because they have done a really great job of overviewing the current management of small cell lung cancer in systemic therapies and also in radiotherapy. So my idea is to give more insight on the breakthroughs that we have seen during the last months in the treatment specifically of early stage disease in limited stage small cell lung cancer. I am Noemi Reguart, as mentioned before, and I'm settled in Barcelona, in Spain. Here are my declarations of interest. When we think about evolution of therapies in limited stage small cell lung cancer, one thing it's clear, and it's that unlike non-small cell lung cancer, we have seen very little advances in the last 3 decades. And probably we have seen a lot of advances or some advances in terms of the use of radiotherapy, PCI, different schedules of radiotherapy, thoracic radiotherapy. But the reality is that when we look at the advances in systemic therapies, there have not been any. And indeed, cisplatin etoposide continues to be till now the standard of care for patients with limited stage small cell lung cancer. And it's very important to keep one thing in mind when now that we are going to look to all the data with new trials. It's very important to keep in mind that in limited stage small cell lung cancer, unlike extensive stage small cell lung cancer, the aim is to cure. In there, we need to have huge differences in or advances or trials and drugs, new drugs that provide a huge difference, a huge improvement, because we want to cure a higher rate of patients. And the reality is that right now, or till now, the cure rates of patients treated with concurrent chemoradiation was not that high. Indeed, if you look at the curves, at 5 years, only 1/3 of the patients are cured. Most patients are relapsing the first 2 years of the disease. So we needed to raise this bar, and we needed new therapeutic advances to provide greater benefit to these patients. And as I said, it has been very nicely overviewed before. Just to keep in mind that guidelines, the concurrent chemoradiation with or without PCI has been the cornerstone treatment for the limited stage small cell lung cancer. And both guidelines, more or less, the ESMO guidelines and the American guidelines recommend the same patterns, giving chemotherapy with radiotherapy. The earlier, the better. They prefer cisplatin over carboplatin. Both radiotherapy schedules are allowed or recommended, once daily or twice daily. And as we will commented more later on, the use of PCI, it's more or less recommended. ESMO guidelines recommend PCI in patients that do not progress, whereas the NCCN guidelines also recommend MRA surveillance as an alternative. But the reality beyond guidelines is very different. And I wanted to put here this case of mine because this reflects what we see in the everyday clinical practice, and is that the patients sometimes have worse ECOG performance status, they can have comorbidities, they can have higher symptom burden at presentation, they can be elderly, or they can have some problems in terms of feasibility and logistical challenges for radiation delivery. So, despite we want to give chemoradiotherapy as soon as possible, we want to complete all the radiotherapy treatment. Sometimes what happens is that we have to start at the third treatment, the radiation therapy, and sometimes the patients have toxicities that impair the ending of the initially planned radiation, dose total radiation. And then we have some patients that are going to relapse, and then we have pneumonitis. And we know that this is a problem for our patients. It impairs quality of life, and a lot of times it requires corticosteroid treatment. So this is the reality. So patients are not perfect, and we have to adapt and individualize treatment decisions. But one thing is very important. When we are talking about extensive diseases, small cell lung cancer, when we are facing limited stage, we need a multidisciplinary management, because as mentioned before, some patients are going to require maybe surgery. So we need to have radiation oncologists, we need to have radiation oncologists, we need to have surgeons there. So we need a multidisciplinary management. And then we need radiologists also for an appropriate staging. And it's very important to provide a timely treatment. The sooner we start the treatment, the better. And immunotherapies have changed the outcomes in patients with extensive stage small cell lung cancer. So that means that in a small, but in a subset of patients, we are seeing benefits by adding immunotherapy to the standard chemotherapy with platinum and etoposide. And indeed, both atezolizumab, durvalumab, and also serplulimab have been approved in combination for the first-line treatment in patients with extensive stage small cell lung cancer. And there are more, because more recently we have seen other advances and new immunotherapies, such as DLL3 BiTE tarlatamab, has also demonstrated to be effective in the treatment of relapsed advanced small cell lung cancer. And indeed, it has been very recently approved last year in May for the treatment of these patients. So it makes sense. Immunotherapy works at least in extensive disease. So there was hope that maybe the addition of the immunotherapy and immune checkpoint inhibitors could also work, not in the advanced setting, but also in an earlier setting after the standard chemoradiation treatment. And the first attempts to explore this idea of adding immunotherapy in an early stage of small cell lung cancer came from the STIMULI trial. This was a small phase 2 trial that sought to determine whether immunotherapy could provide an advantage, a benefit in this challenging setting of early stage small cell lung cancer. And they randomized patients who received nivolumab, ipilimumab, 4 cycles compared to observation, followed by nivolumab up to monotherapy up to 1 year. This trial was controversial because it has to be closure before ending the initial estimated of patients, so there was a slow recruitment, but never mind, as you can see there, the curves, the trial was negative, could not demonstrate any advantage of adding immunotherapy after the standard concurrent chemoradiation. 2-year overall survivals were the same, 60% in each arm, and there were a lot of concerns because there was a high grade 3 toxicity and also 50% of treatment discontinuations. Nonetheless, I think there was still interest to continue exploring immunotherapy despite these negative results of the STIMULI trial. And several other trials continue exploring this idea of adding immunotherapy to the concurrent chemoradiation therapy in 2 main strategies. One strategy, giving immunotherapy after the concurrent chemoradiation treatment as consolidation therapy. And another different strategy is to give the immunotherapy together with the initial concurrent chemoradiation. And for that, several trials, as you can see there, phase 3 trials have included checkpoint inhibitors that indeed have demonstrated to be active in extensive disease, such as durvalumab, atezolizumab, pembrolizumab, or serplulimab. But for sure, the trial that has represented a higher impact and the landmark study with immunotherapy in limited stage small cell lung cancer has been the ADRIATIC trial, because this is the first trial that with results that has evaluated which was the role of immunotherapy when added as consolidation after concurrent chemoradiotherapy. So let's have a look to this trial with more details. The ADRIATIC trial is a randomized phase 3 trial. It was a placebo-controlled trial, international study, and included patients with limited stage 1 to 3 small cell lung cancer with good performance status 0 and 1. Patients had to had received previously concurrent chemoradiation as per local standard of care, and there had to be demonstration of no progression after this treatment. Prophylactic irradiation was permitted, but was not mandatory. A total of 730 patients were included and randomized to receive durvalumab, placebo, or a third arm with durvalumab and tremelimumab. One important thing is, as I said before, the concurrent chemoradiation was allowed as per standard of care, and both cisplatin and carboplatin were allowed. Also, both radiotherapy schedules 1 daily or twice daily as with the standard doses. And one very important thing is that radiotherapy had to be initiated no later than the second cycle of chemotherapy. Another important aspect of the trial is that the initiation of durvalumab or the randomization of the patient had to occur from immediately after the ending of the radiotherapy, the PCI or the thoracic radiotherapy, up to 6 weeks, 42 days after the end of the treatment. Patients were stratified according to disease stage and also according to PCI. Dual primary endpoints were overall survival and progression-free survival, and the first results have been provided for the first two arms, for durvalumab and placebo arm, whereas the third arm with durvalumab and tremelimumab remains blinded. Here, the characteristics of the patients included overall, as you can see, were balanced, very well balanced between durvalumab and placebo. Median age probably a bit younger than what we are used to see, and it was mentioned before by the previous speaker, 62 years old. There was a nice, a consistent representation of according to race, white and Asian patients, and also very nicely to see how there was a broad representation of all the different treatment patterns that we can use locally. Cisplatin etoposide was used in 2/3 of the patients. Once daily radiotherapy was preferred in 2/3 of the patients, whereas PCI was selected by 50% of the investigators. So we had there 50-50 patients treated with PCI or without PCI. 1/3 of the patients completed the 2 years maximum treatment. However, if you look the reasons for this continuation, the main reason was disease progression, which is quite reasonable because most patients relapse the 2 first years of disease. And here the results. Remember, two primary endpoints, overall survival and progression-free survival. The trial met both primary endpoints with a median duration follow-up of 37 months and data maturity of nearly 50%. Treatment with durvalumab demonstrated a significant and meaningful improvement in 2 years overall survival over placebo. Median overall survival was 33 months with placebo compared to 56 months with durvalumab, with a hazard ratio of 4.73, and at 3 years on treatment, 56% of the patients treated with durvalumab were alive compared to the 47% of patients treated with placebo. One important thing here is to look at the placebo median. As you see, it's 33 months, which is a bit higher or exceeds a bit what it was the Conver benchmark that was established at 25-30 months. However, keep in mind that the inclusion criteria of this trial was quite more strict than the Conver trial, as in this study, patients that progress after concurrent chemoradiation were not included. So it's also reasonable that the median overall survival for the placebo arm is a bit higher than the Convert trial. Second primary endpoint, progression-free survival, was also met. 2 years treatment, 46% of patients with durvalumab and versus 34% of patients treated with placebo stayed in remission without a relapse for a median PFS of 9 months. Patients treated with placebo versus nearby 70 months with durvalumab has a ratio of 0.76. One very nice thing to look at the curves when you look at the curves is that first that you see that the most patients relapse within the 2 first years of disease. The curves separate early, and then you see how they widened over time, remaining flatter after 2 years time point. And this is very important because reinforce the strategy selected in the ADRIATIC trial for giving immunotherapy for 2 years after concurrent chemoradiation therapy. When we put together all the data with durvalumab in the different settings of the disease and also in non-small cell lung cancer, we see that the benefit provided by durvalumab as immunotherapy it's very different indeed. If you compare, there's a sharp contrast between the magnitude of benefit with durvalumab in limited stage small cell lung cancer, which is 23 months, compared to the 2 months that we are seeing in the advanced metastatic setting. But in the other way, if you look at the data in the Pacific trial in non-small cell lung cancer, which is also a potential curable setting, you see that the benefit, the magnitude of benefit, is more consistent with what we are seeing within the ADRIATIC trial. And it's not clear why immunotherapy is working better in these earlier stage lung tumors than in the advanced stage. And there might be different explanations for this observation. Maybe patients have a more immunocompetent host, or maybe it's because we are giving it radiotherapy before, and this is providing a synergistic effect with the immunotherapy, or maybe because immunotherapy has a greater ability to target this micrometastatic disease in an early stage. Whatever the reason, underlying reason, what is clear is that earlier detection, early introduction of treatment provides better outcomes in patients with lung cancer. When we look at the subgroup analysis, we see that overall survival favored durvalumab compared to placebo in all pre-specified subgroups, according to the different patients' clinical characteristics, and also according to the different treatment patterns used as per standard local of care. This is good. One observation it's nice to see is that it seems that those patients that start durvalumab earlier, after the ending of concurrent chemoradiation, seem to have a higher benefit from durvalumab than those patients that started at a later time point. However, this data must be taken into account because the trial was not powered for subgroup comparisons, and also these patients might only reflect a better selection of patients with a more favorable clinical characteristics. I could say that it might be therefore reasonable when we are having patients that are at the end of concurrent chemoradiation, if the patient is fit enough, I could say, let's go ahead and treat with immunotherapy with durvalumab as soon as possible. However, I think it's also reasonable in those patients for which we are seeing toxicities derived by the treatment or by the radiotherapy on patients that are fragile, it might be also reasonable to start immunotherapy with durvalumab at a later time point. Here we are. Very important also, we had a lot of interest to see how were the outcomes of those were subgroup analysis. That was not the endpoint of the trial, but to understand whether durvalumab, or how were the outcomes of the patients treated with durvalumab according to the different treatment patterns that were used as per local standard of care. And we said that radiotherapy, PCI, 50% of the patients received PCI. Both carboplatin and cisplatin chemotherapies were used, as well as both radiotherapy schedules, once daily and twice daily. So was there was a lot of interest to know whether the patients' outcomes based on these different treatment patterns. And as you can see there, the curves, those patients that receive twice daily radiotherapy, both arms, not only durvalumab arm, both arms with durvalumab and placebo, seem to perform better than those patients that were treated with one daily radiotherapy. And another very interesting observation, you see it on your right, is that those patients that receive carboplatin seem to derive higher benefit from durvalumab. Again, careful, the interpretation of this data might be biased. I think the data reinforce what we tell us is that whichever the treatment strategy we are using there, we are going to see benefit from adding durvalumab consolidation. And our previous colleague has talked about PCI. It has been nicely reviewed the data. that we have right now, what is clear is that the use of PCI in patients with limited stage small cell lung cancer decrease the risk of brain metastasis by approximately 20%. We have more data on overall survival in demonstrated that improves overall survival in patients with limited stage small cell lung cancer. In extended disease, we have some controversial trials. However, very important, all these trials, all this evidence was in the era in which we were not using immunotherapy, and also in an era in which we were not using MRI imaging as per standard of care. So that's why right now there has been a general trend in the field moving away from PCI because a lot of investigators think that we need more data with immunotherapy, with MRI, to be sure that PCI indeed is improving overall survival. And in the ADRIATIC trial, we had 50%. It reflects these changes in patterns, decisions by the investigations, because only 50% of the investigators use PCI. And when we see the outcomes in the ADRIATIC trials, in the patients that receive PCI compared to the patients that did not receive PCI, you see there in the curves, patients that receive PCI seem to derive higher benefit from durvalumab, but also in the placebo arm compared to those patients that did not receive PCI. Again, that doesn't mean that PCI has a direct effect there. It might be only reflect a more selected population of patients. We need more prospective data to confirm the benefit of PCI in the era of immunotherapy. And that's why we have right now two important phase 3 trials ongoing, the Maverick trial and the PrimaLine trial, which are going specifically to explore this, which is the role of PCI in the era of immunotherapy and in the era of MRI imaging. So I guess these trials are going to give us much more information on whether we have to use PCI or what's the benefit of PCI itself when using immunotherapy. Let's go to the safety of durvalumab. This was very, very important, and it was important because those are patients that had been previously treated. It's not that it's the first treatment we give, but it's a treatment that is given as consolidation after a treatment that is has some toxicity, which is concurrent chemoradiation. So there were concerns that maybe this immunotherapy could worsen the side effects of the patients. And indeed, that was not the case. Indeed, the tolerability of durvalumab as consolidation was impressive. Look at the maximum grade 3/4 adverse events were exactly the same in both arms, 24% with durvalumab and 24% with placebo, and the adverse events leading to discontinuation indeed were very low in both arms. As expected, most common adverse events were, one of the most common adverse events were radiation pneumonitis. If you see the distribution of the adverse events were consistent in the placebo and durvalumab arm, the majority of the adverse events were mild and manageable, and there were very few grade 3 4 adverse events that were also really nicely distributed in the placebo and the durvalumab arm. Grade 3/4 adverse events, as expected, were higher in patients treated with PCI, were higher in patients treated with carboplatin, and slightly higher in patients treated with once-daily radiotherapy. However, adverse events leading to durvalumab discontinuation were very similar across subgroups, so everything as expected. One very interesting thing about the ADRIATIC trial was regarding the pneumonitis, and this was very important because radiation pneumonitis is a side effect that impairs quality of life, and we commonly see in the patients that are treated with radiation radiation in the thorax. So there was a lot of interest to know which were the features of pneumonitis in the ADRIATIC trial and how they were addressed. And indeed, the rates of pneumonitis in the ADRIATIC trial were very consistent, very similar in all grades in patients treated with durvalumab and in the patients treated with placebo, 38% all grades with durvalumab, 30% with placebo, and grade 3 or higher adverse events were less than 3% in each term. And this data is exactly the same data that it was reported in the CONVERT trial and in the PACIFIC trial. Although important, again, to keep in mind that in the ADRIATIC trial, the inclusion criteria was a bit more strict. Remember, patients that had pneumonitis grade 2 or higher were not allowed to be included in the study, and there were more strict criteria in terms of radiation fields. Baseline characteristics and prior treatment patterns were homogeneously distributed in patients treated with those patients that developed pneumonitis and the patients who did not develop pneumonitis. And the only thing maybe to highlight in here is that in those patients that were from Asian origin had a higher incidence of pneumonitis, which is something that has been previously reported. Nicely to see how were the onset and resolution dynamics of pneumonitis at the time of the first dose to the onset of pneumonitis the timing was, the median was the same for both arms, approximately 2 months, and also time to resolution was lower for patients treated with durvalumab than the patients treated with placebo. However, maybe because the investigators were afraid of the side effects of durvalumab, although the data do not reinforce a higher toxicity in terms of pneumonitis, but the reality is that a higher number of patients were treated with corticosteroids when receiving durvalumab, and also a higher number of patients discontinue because of the treatment. However, if you look at the rates of pneumonitis results were very similar between both groups. Very, very important, patient-reported outcomes. This is very important. We want to give a treatment that it provides a great magnitude of benefit in terms of outcomes, but we want to preserve the patient-reported outcomes from symptoms, and this indeed was demonstrated also in the ADRIATIC trial. There are, however, a lot of unknowns that we need still to resolve, or we need to have more information about, and one of them is the biomarkers. We don't have biomarkers for immunotherapy selection. We don't have it in advanced disease, and although we know that there have been a lot of, we have more data on the different transcriptional classification of small cell lung cancer, the reality is that these transcriptional subtypes cannot be used as a biomarker for selection of immunotherapy. So we had to wait, maybe this year, maybe next year, we will have for sure more data on the biomarker exploratory analysis from the ADRIATIC trial that it's going to give us more insight, or maybe some insights of which is the role of these different biomarkers in an early setting of patients treated with durvalumab. Another very important question is if timing matters when adding immunotherapy. I said before at the beginning that there are 2 strategies that are being studied. One, consolidation, that is the ADRIATIC trial, but another strategy that is being explored is to add the immunotherapy together with the radiotherapy. And there are 3 pivotal trials that explore this strategy, and we already have results for the first trial, which explore the addition of atezolizumab together with concurrent chemoradiation, followed by atezolizumab 1 year. However, unexpectedly, probably these results, the trial was completely negative, could not demonstrate differences, which is which is striking, because if you look at the curves and you see the curves, the 2-year benefit in overall survival from the Pacific trial, it's incredible. So there might be something there that it's explaining why there are this huge difference in the two trials. And one of the most important difference between the trial, well, I could say there are two. The first one, in this one, they use just immunotherapy for 1 year. And the other very important thing is that in here, you are not selecting the patients that have responded, that have already received concurrent chemoradiotherapy. In here, you are including all the patients and you are giving their immunotherapy together with radiotherapy. So maybe what we are seeing here is that radiotherapy must be given before to synergize, to provide this microenvironment that favors the immunogenic response. Another important question that remains to be answered is what to do in patients with high subgroups. The ADRIATIC trial, it's a very nice trial, but also it was very strict in terms of the eligibility criteria. And at the end, not all the patients we see in the clinical practice are going to be able to receive concurrent chemoradiation. Indeed, 10% of the patients are candidates to receive sequential radiation. And another thing is the inclusion criteria were very strict in the ADRIATIC, and not all the patients can start, for example, the radiation at the second, before the end of second cycle. Sometimes we have to start at the third or fourth cycle. So we don't know if the benefit of durvalumab could be the same in this specific trial, in these specific patients. And this could be very nice to have trials addressing specifically this patient population. And that has been done indeed in another setting of patients with locally advanced disease with non-small cell lung cancer. You know the results, recent results of the Pacific 5 trial that support the use of durvalumab in those patients that receive sequential chemo radiation. So could be very nice to have an ADRIATIC 2 trial in these specific patients, a group of patients that cannot receive concurrent chemo radiation. And the future, well, is there. We do have these two trials that are still exploring the concurrent chemoradiation. We will have the results sooner this year or next year. And there are other trials, very nice trials, that are exploring also the consolidation strategies in the early setting, but using not immuno or new immunotherapies, such as the Delphi 306 trial, which is exploring consolidation therapy with tarlatamab 1 year after concurrent chemoradiation, or the Artemis trial, which is a more innovative, I would say more risky trial, which is exploring the use an B7H3 ADC based only on the results, a small phase 1 trial, also given after concurrent chemoradiation, but in this case, not for 1 year, but until progression of disease. So these trials are going to be important because are going to give us more information on the importance of the duration of treatment. Of course, these trials will not have the optimal control arm, which could be durvalumab right now, and also how the quality of life will impact or will be the quality of life will impact the efficacy benefit. So this is my last slide, and brings me to the end of my presentation. ADRIATIC for sure represents the first practice-changing study in decades and the first positive immunotherapy trial in limited stage small cell lung cancer. Durvalumab consolidation is a new standard of care in patients without progression following concurrent chemoradiation, both with and without PCI, with a very favorable risk-benefit profile. There's ongoing research, and we do have many many challenges to address. We will have to follow up on new updates on the ADRIATIC trial with longer follow-up and all the other pivotal trials to define the optimal immunotherapy sequencing, and also these new therapies that are being explored. We need a lot of information in all these group of patients with high risk groups that are not eligible for concurrent chemoradiation or for the specific ADRIATIC criteria. We need to clarify the role of PCI in the era of immunotherapy. And for sure, as always, it's very important to personalize therapies and to find biomarker-driven strategy approaches. And with that, I finish my presentation and I hand it over to my colleague for all the cases discussion. Thank you so much for your attention.
Thank you, Dr. Naomi. That was wonderful. My only problem is you have almost covered up almost everything. So I really don't know what will I discuss now.
But it's always nice to repeat everything. Don't worry.
So we will ask you to repeat everything again because but it was a very, very nicely concise and, very importantly, you covered all the points, whether they were included in the trial and what are the real problems which we can face in the real life actually. So what I'll do is I am going to share my slides right away and okay. Okay, so can I invite my panelists? I think we have 3 or 4 medical oncologists. We have Dr. Chandrakanth, who has given the first case, Dr. Deepak Kopaka, who has given the second case, Dr. Soumya Sarath Panda, he's a medical oncologist. I think we are running short of radiation oncologists now. Dr. Srinivas, I think, hasn't joined. So can I request Dr. Shashank Srinivasan to join us as not as a AZ representative, but as a radiation oncologist? Okay. Okay. So, let's just talk about the treatment strategies in small cell lung cancer. My first reactions whenever we used to speak about small cell lung cancer is exactly like this. Now, this is where non-small cell lung cancer is. This is where all the innovations, targeted therapy, and every therapy is. And this is where the small cell lung cancer is. So, that is why it was like this. But my subsequent reactions are that, things will change. All things are difficult before they actually become easy. And this is, how India built up a rocket. In 1960s, we got the rocket. This is how the Space Center was first taken. And almost on a bullock cart, we wanted to go to the moon. And now we actually have reached up to the moon. So, the things will change. Things will get better. So, this is a case which has been provided by Chandrakanth, a 54-year-old male, smoking, chain smoker with a 30-year pack history. He had history of cough, breathlessness, and hoarseness of voice. A bronchoscopy was done, which had a small cell lung cancer. So my first question, I'll stop everyone here, and this question I'll send you to Deepak to start with you only. Does your pathologist always ask for IHC even if it is a small cell lung cancer? I mean, so small cell lung cancer, pathologists also have become very defensive in their approach. So do you think small cell is a morphological diagnosis, or they still put some synaptophysin and Ki-67 high and then take a thing on that? Deepak, you're muted.
So most often, if the mitosis is high and the morphology is typical of small cell, they end up not doing IHCs. So
Fantastic.
most of the morphological diagnosis at our center.
But I mean, if you come to the north of Delhi, north of India, a lot of people will still want to just put 2 IHCs. A lot of times we should tell people, for the younger audience who are listening, TTF1 will also be positive in small cell, as would be synaptophysin and chromogranin. So just don't get worked up by TTF1 and start thinking in terms of pembrolizumab and stuff like that. A PET scan was done for this patient, which revealed a limited stage disease, which was characterized by a right hilar mass and a bulky lymphadenopathy. MRI brain was done, which did not reveal any mutations. And this was the we can see over here, there is a mass in the lung. So let me come to Dr. Soumya. Soumya, let us say this patient was non-small cell lung cancer. and a patient has a N2 lymph node and has a right upper lobe mass, the first thing that we will do as medical oncologists and the surgeons will do is get an EBUS done and get the, EBUS guide FNEC biopsy to prove lymph nodes. And that time we say, because in India, 30% of people can have tuberculosis, we want to see whether lymph nodes are positive or negative. But in small cell lung cancer, the moment it is this, nobody will utter the word EBUS. So from a radiation oncology point of view, or from your point of view, I think if Shashank is here, I'll ask this question to him too. Do you guys do EBUS? In our institute, they don't do EBUS if it is positive, if it is comes as small cell, because they feel that they're going to irradiate all the lymph nodes. But do you think we should actually be doing EBUS and then the radiation field will change for you, Soumya?
Yeah, so somebody who is having patient non-small cell, definitely yes. But when it comes to small cell, mostly
Nobody does. Nobody does. Okay. Okay. Let me ask Shashank. Shashank, are you here?
Sir, yes, sir.
Yes. So Shashank, should we? I mean, does the portal change, radiation portal change if the lymph nodes are positive, negative? Once, if all of this is negative, even my surgeon will be interested. I mean, very few times when they get to operate on a small cell. But do you think the portal will change if the lymph nodes are N1, N2, N3? How does the radiation portal change in case of small cell?
So we've had this discussion in the past as well. For small cell, it really does not change at this given point in time with everything that we have. It is usually a lot of central disease, a lot of mediastinal lymphadenopathy, and
you will include. So, whether irrespective of the mediastinal lymph nodes, will you include an N3 side also, or you will involve everything which is positive on the CT scan? You will include that.
So whatever is visible, no prophylactic irradiation per se, as far as the mediastinum is concerned.
Let us say I did an EBUS for this patient and it comes as AFB positive.
I know where you're going, sir.
I know. I mean, we have had this before, but radiation oncologists don't change. I mean, I have been trying to push them into doing EBUS. So let me ask Dr. Noemi Reguart. Dr. Noemi, what would you do?
Well, we are not using EBUS really I think the use of EBUS makes more sense, isn't it, in non-small cell lung cancer than in a small cell. And I think it's because it's not that it's not important. I think,
Shashank, just 1 second, Dr. Noemi. Shashank, I think you'll have to mute yourself. Shashank? I think Shashank is some points of having. Can the administrator please mute Shashank?
Here, no.
Yeah. Yes.
Here. Yes. So I could say the thing is, when you are considering surgery for these patients, I mean, even if you have one node positive, you are not going to. So surgery is very selected. So at the end, if you have in a PET CT that you have N2 disease, N1 disease, so you are going to go for chemoradiation. So that's why we are not doing EBUS in patients with small cell lung cancer. We can use EBUS as a diagnostic tool.
Okay.
Not as a way of staging to decide treatment strategies. And as our colleague said, our radiation oncologists use PET-CT for all the radiation field strategy.
So, I mean, I think that, Dr. Noemi, I totally agree with you. But the point is, in India, we do see that 30 to 40% of people have got endemic tuberculosis. So to me, I mean, I would actually want a country-specific radiation oncological driven investigator-initiated trial to really see that if these lymph nodes are positive or tuberculosis is there, or if they're positive, whether the radiation field will change and whether it will have a some kind of betterment in the prognosis, and the radiation fields might differ. But that's just a point for the future. So we basically got an MRI brain for this. So I will just go to Dr. Soumya. We do MRI brain for everyone?
Yes, sir.
We do it. Fantastic. Okay, let me go to Chandrakanth now. So Chandrakanth, your questions only, but do you think it makes a difference? We are medical oncologists. Sometimes it is very easy to start with. It also depends on where you practice. Radiation oncology slots are not really available easily in a government center. Medical oncology, you can start the treatment today evening or yesterday morning. Yesterday. So do you think giving 2 cycles of chemo is easy? and then reassess even the patients, you will look at the biology of disease, you will select the good biology of disease and then go ahead, or you say, no, I'm a sticker, I will want to go ahead with CCRT. Chandrakanth.
Right, sir. So thank you, sir, for the question. So we give at least one cycle of cisplatin or carboplatin etoposide, and we would want to start radiation at least from the second cycle onwards. We do not want to delay beyond that.
Okay. So you do not want to delay beyond 2 cycles, but you want to go ahead with one cycle of chemotherapy before.
Yes, sir. We can at least give one cycle of chemotherapy before. At least we want to start from day 1 of cycle 2.
You want to start the treatment as early as possible and then probably include RT in the second cycle. Is that what you are saying?
Right, sir. Right.
Fantastic. Dr. Soumya, your practice?
Yes, sir. So the same thing. Because mostly if we look at this trial data, so we had this ADRIATIC trial where up to cycle 2, day 1, they had included that. So RT has to be there before the second cycle. So before that also, actually, in these patients, the patients, they usually come to the medical oncology here, and then we start on the chemotherapy, and then refer them for the RT, addition of RT to the radiation oncologist. That's how it goes here.
Okay. So we have some very strong medical oncologists here. Dr. Noemi, how does it happen at your center?
Well, the same. I think there's data that supports the use of the earlier the better the radiotherapy. So that's an evidence, no doubt about this. However, that's not the reality. The everyday clinical practice. I'm sure you are lying if you say that all your patients are treated at the second cycle, because you have older patients, you have patients with toxicities, you have patients that, I don't know, you have problems scheduling the radiotherapy, whatever the reason is. And at the end, sometimes we start the third cycle, and other times we do it sequentially.
So let me ask 3 questions to you, Dr. Naomi. So let us say somebody has got, because of poor performance status, only 1 cycle chemo and then got RT alone. Will you consider that patient for ADRIATIC trial? RT alone. PS2.
RT alone without chemotherapy, you mean?
Yes, on no chemotherapy, patient could not take. They took 1 cycle, was performance status, got esophagitis, and real world. AstraZeneca can close their ears right now.
So that question is tricky, because no, I think the magnitude of benefit of the ADRIATIC is so huge that I think even if a patient is not meeting specifically the criteria of the ADRIATIC, if the patient is fit enough, I think I could go for it.
You would go for that. That's true medical oncologist.
Yeah, but the thing is, as I said in my presentation, we don't know exactly why immunotherapy is working so well in this setting. So we don't know exactly whether we have to use the complete use of radiotherapy or if we have to start at the second cycle, of which of these aspects are important in providing this magnitude of benefit from. So I could say we have to recommend to do as in the clinical trials, but I could be flexible. That's it.
So just a small question, Dr. Naomi. We had Pacific R studies. So should Astra name it an ADRIATIC R or ADRIATIC flexible? ADRIATIC F or ADRIATIC R study?
Exactly. That's what I say. We need an ADRIATIC flexible trial.
Yes,
yeah.
you need an AF study, which will tell exactly where we are.
Okay, yeah.
So Dr. Deepak,
Yes.
let's say patient has taken RT-CT, patient has taken 10 weeks to recover from, the toxicity. Would you give ADRIATIC R, ADRIATIC Flex, or you will say, no, I'm a sticker for this. I'm asking all these questions to you, Deepak, because your case is coming up next. And you have me stumped on that case.
Yeah, I mean, I thought so. Before sending the case, I asked twice. Ask Ullas, sir, if that's okay.
No, I will show you something. Okay, go ahead.
But again, I think I would definitely, like Dr. Naomi was rightly saying, I think the benefit is so huge. I wouldn't really withhold the drug in these group of patients because they're significant, prolonged PFS also, for that matter of fact. So I think it's still worthwhile trying to delay that recurrence and yeah. I would say, my practice, I would. Yeah.
Dr. Chandrakanth, PCI, you like radiation oncologist? You don't like radiation oncologist?
Right, sir. So if a patient is elderly and has already some cognitive impairment, if a patient is agreeing for MRI surveillance, I would agree for MRI surveillance, because these patients are likely to live long, like not before they used to die in 2 years. Now they can cross 4-year, 5-year mark or even longer. So we really don't know this PCI guys. I know the hippocampus is spared. So if there is an opportunity to avoid PCI and the patient accepts for the strict MRI surveillance, why not? I would avoid PCI in these patients.
Let me ask Dr. Naomi, clinical trial we heard from you, but PCI in your real practice, with a hand on your heart, how many people you go ahead with PCI, how many people you say, and a hand on your heart?
Yeah, I know that my radiation oncologist is not here right now, so please give you my opinion on this. I do think there's not enough evidence right now to be sure that immunotherapy, what's the benefit of PCI itself from this patient. So it's what the doctor commented right now, that at the end, these patients are going to live very long, with maybe 5 years after durvalumab, and we're going to see long-term neurotoxicity in there. So I would be happy to have to be more convinced by these 2 trials that are ongoing right now, the PrimaLang trial and the Maverick trial. I like to see this data to be sure. In my clinical practice, I prefer to follow them with MRI.
Okay, fantastic. So I think we are all convinced, and just for the list one, Dr. Soumya, 4 cycles, 6 cycles of chemotherapy?
Mostly we complete 4 cycles.
Okay.
Assessment, if the patient is doing well, then we directly go to the immunotherapy.
Okay, so just to summarize, 1 cycle or 2 cycles of chemo to start with. Do not start chemo radiation later than a 3rd cycle, but start it as early as possible. Just because it was allowed in the trial, don't wait till 3 cycles. After the 2nd, 3rd cycle, we are all convinced regarding durvalumab data. However, PCI, we will want to discuss with the patient, and they have to be on a strict surveillance of MRI, which needs to be told to them. And the rationale of that also needs to be told to them. And we should do a clinical trial also to find out. This patient got 2 cycles of chemo, then got RTCT, and then did very, very good. The guy was started on durvalumab maintenance, and this patient was not given PCI and was given on MRI this thing, and is doing reasonably okay right now. So that is also a strategy. That's something that was the first case, which we are all convinced. This is the second case, Dr. Naomi. I will like to chew your brains a bit on this case. 10 more minutes. We have 2 cases. 44-year-old male clinical scientist, non-smoker, came with history of cough, chest pain, and shortness of breath. This case has been provided by another panelist, Dr. Deepak. The X-ray has been was done, which shows like this. A CT scan mass, which again basically shows a central mass, necrotic right hilar paratracheal mass. There are multiple liver metastasis in a non-smoker patient. And as we can see that there are multiple lung nodules and a lung mass over here. A PET CT scan was done, which basically came as liver, skeletal, lung mets. And a biopsy was, this is again the PET scan, which basically shows. And just in case you are wondering, Dr. Naomi, the cost of PET CT scan in India is much more cheaper than a CT scan, chest and abdomen combined. So that is why PET scan is done very, very, very frequently, actually. And that is why everybody will get a PET scan.
You're lucky.
We are lucky on that. Thank you. So anyway, this patient got a biopsy done. And just so that there is no confusion, Dr. Deepak has given us, that there is nothing. There's small cell lung carcinoma, and synaptophysin Ki67 is also positive, more than 80%. And that's in black and white, they're written small cell lung carcinoma. Fantastic. Unfortunately or fortunately, because this patient also was a non-smoker, and this is what I will also do, and I will show you certain things in that, Dr. Deepak. NGS was sent. And the NGS basically showed a EGFR mutation L858R. I will tell you what I will do if I get this report at 9:30 in the night. I will frantically call up my resident and ask whether the small cell cancer only was or non-small carcinoma was, and did we miss a non-small cell component? But this is it. So an EGFR with a VAF of 67.57% and a good lab, I would say, and some kind of, TP53 mutations also were seen in that. This may have a value, Deepak.
Yes,
And
sir.
this
Yes.
histopathology was reviewed. I think it was, so what they did was they got a repeat liver biopsy now done. And the liver biopsy also was saying in small cell carcinoma. Now what they have said, in which I don't agree with, is that EGFR mutation is seen in 4% small cell carcinoma. I will not really agree with this statement. Typically, it is not seen in my practice, but so you have a lung biopsy, which is small cell, liver biopsy, which is small cell, done twice, NGS done, which is EGFR and P53 mutation was done. So this was the block for IHC. They also got a second opinion done on that. So Dr. Deepak did not want to leave anything to chance. He said, no, we will get in a second opinion. And so let me go to Dr. Soumya first, then Dr. Chandrakanth, and then Dr. Noemi. Dr. Soumya, what will you do? I think Dr. Soumya has some internet issues. Chandrakanth?
Chemo TKI, sir.
Chemo TKI. So you would give etocarbo and osimertinib.
Just to add, I given those details
Yeah.
here. So at 9:30, I don't have residents, so I called the lab back.
Okay.
I called the lab and I asked, boss, you've run an entire sequencing. Was in EGFR amplification present, and did you have LOH? None of these were present as such, because that VAF was way too convincing to
Fantastic.
consider it as a driver mutation. So again, I'll just add that one point before we move forward. Yeah.
My lab person would have asked me, boss, Beja, why did you send a NGS on a small cell carcinoma? That is what they would have asked me. Okay, so Chandrakanth, you are saying etocarbo osimertinib.
Right, sir. So he is never smoker. Therefore, sending a NGS is valid in this patient.
Okay.
So I agree. I think etocarbo OC is a reasonable option for me.
Okay. Dr. Noemi?
Yeah, the same. I would not for sure give immunotherapy.
Okay, yeah. What we will not do is give ADRIATIC. We will not give Caspian or this approach. We will not do that. That's something which is very, very sure. The choice of chemo, Dr. Noemi?
So if the patient is young, well, I don't know. In this case, I don't know if patient is young and it's fit enough. Maybe I could be more pro to give cisplatin, but only because I used to in my clinic I used to prefer carboplatin, but as this case it's a strange case and you don't know if patient is young, I could use cisplatin. I could use etoposide. I would not in any case use pemetrexed. You have to think that those patients are neuroendocrine tumors, and it's known that these patients with neuroendocrine features do not respond because of thymylate synthetase to pemetrexed. So never pemetrexed. I would use etoposide, and then if I could, and they allow me, I would introduce osimertinib, because as seen in your biopsies, seems that there is it has different components, cellularity components. Probably there are cells that are more neuroendocrine, and other ones are we have more the mutational clones. So I would love to give both.
Yep. So I will just show you. This is one case which we had reported and treated in COVID, which was a EGFR mutant synchronous small cell lung cancer and adenocarcinoma. So in this patient, we had given etosis to start with, and then we had given osimertinib after that in the end. So there were two components. Adenocarcinoma also had del-19, and the small cell component also had del-19, and we had given this treatment. So, and this was my first JTO-CRR publication, so very close to my. It was just started at that time. So what also I would like to show you in that, Deepak, is you look at this TP53, which was positive. I think if you do a more this thing, you will also find an RB gene this thing. So maybe there was an adenocarcinoma component somewhere with what Dr. Noemi is saying, which has basically got transformed into kind of a small cell. So probably if you would have done, in fact, we just had a patient today who is over there. That patient has got surgery done, has a 85% component of adenocarcinoma, 15% component of small cell carcinoma, EGFR mutant. We called him for surgery. The guy has got mets everywhere of small cell. So the more NGS you do on this non-smoking, my thing is it's a de-differentiated adenocarcinoma which has gone on to this thing. So I would probably give etosis. Then I will want to give osimertinib. Sequential only because there's no data of combining etosis with osimertinib and I don't want to take that risk. On progression, I would rebiopsy and probably do a weekly Paclitaxel or something of that sort. But this is something which we are seeing a lot common. In fact, we have ALK seen in adenocarcinoma and small. We have one patient who was transgoing into adeno, then small female. So we gave etosis, then we gave lorlatinib. She did not respond. Then she is now on to back to the standard regimens on that. So very, I mean, not very common, but we are getting a lot of patients who are doing. Again, the most important thing is EGFR, P53, and look for RB gene translocation, the triple hit theory which comes up. That is what I would say. Dr. Noemi, any comments on that?
No, it's incredible. It's very nice case. So congrats. So I was going to ask, did you use a toposite or pemetrexed?
Etoposide. So I will not use, I mean, only for the fact which you also said that, pemetrexed probably will not work on the small cell component.
Yeah,
so,
that's right. But this case was an adenocarcinoma too.
Yeah. So I thought, so what I initially thought was I will do both etocarb and then I will do PEM plus OC maintenance. That's what I thought at that particular time. But then the patient did not really agree for that and I gave him OC mertinib also. Only.
And what was the outcome with the case? Because normally these patients do not have this long-term PFS. We
18 months, I think, was the.
Well, it's not bad. It's quite good.
Yeah, but we are now used to seeing Pacific and Adriatic and stuff like that. We think 18 months is less now. So I think, Deepak, to answer you, I think we will give etocarb plus minus OC. That is what I would do. But etocarb definitely you start. You can give OC later on also depending upon the cost. That is what I would do. Fantastic.
Thank you.
So we have a small third case also. 55-year-old male, current smoker. Just 5 more minutes, Dr. Noemi. Right central mass, hydrolymphadenopathy. A PET scan was done, which basically said this. And the brain was showing a single solitary lesion. So this is the PET scan, a very small lung primary, but the MRI brain was showing a huge lesion at 3 centimeter into the brain. So now you have a solitary 3 centimeter lesion with a moderate perilesional edema. The brain, everything is all right, and a very small lesion. So, Chandrakanth?
It is small cell. It is small cell, sir.
It's today's small cell day. Small cell, big problems.
Small cell with a solitary brain metastasis.
Yes.
Right. And the mediastinal lymph nodes are not that bulky, no, sir?
They were not that bulky. And we were not even sure. The radiologist reported as it could be query met, it could be query meningioma, as usual, suggests clinical histopathological correlation.
Right.
So you would.
I mean, I would surgery of the brain lesion
for
and consider. Yeah, because we're not sure what it is. No, sir. Like whether it's a METS or a meningioma, we are not sure because unlikely for a small cell which is not bulky to have. Anyways, if you're not sure of what the brain lesion is, I think we need to do an excision of it. If you're sure, then it is metastasis.
We were not sure.
Then treat with a curative intent. CTRT, SRS, and CTRT, and follow ADRIATIC.
This guy will
sure that it is metastatic.
This guy will definitely cure lung cancer. I'm 100% sure. If there's one person who will cure lung cancer,
no, sir. I mean, this is. I will not go for WRT. I mean, this is solitary met. I would.
Fantastic. I will show you what I did. I did almost the similar thing as what you are saying.
Right, right, sir.
So I would do chemotherapy.
You'll do chemotherapy.
I'll do chemotherapy. He's not symptomatic for the brain met, I believe, sir.
No.
So
But
chemotherapy.
there's a huge mass over here. There's a huge mass, 2 point something over there, 25 into this thing, 25, 20, 27.
Into the dura, again, these are all a little favor of meningioma. Again, the lesion being near the dura and all. So 2 cycles, and then I would do an MR. I think that's going to really tell me the biology of this case. So
Fantastic.
the lung would definitely respond, and the brain, if there is no great response, I think probably there doing something for the brain makes sense.
Okay.
And then we can do radiation to the lung.
Fantastic.
Altogether, if the brain lesion
The
is
radiation oncologists don't come to our symposium. We are still giving them business, you know. Okay. Dr. Naomi, what would you do?
That's difficult, but I don't know. I'm quite skeptical to have a patient with a small cell lung cancer with brain lesions not doing nothing and starting just with chemo. I don't know. My experience, it's not very good. So I think I could start with treatment in the brain upfront, together with systemic therapy. What is something that we are more and more considering right now is the use of SRS, which was not, it's not as clear as in non-small cell lung cancer, but our radiation oncologists are more open to use SRS right now in small cell lung cancer, which is, I think it's good.
Our radiation oncologist, somehow I keep on pushing them, come on, give SRS, come on, give SRS, and they are just not taking the bait. Because they know that when it fails, I'm going to eat them alive. Okay, Shashank, what would you do?
So again, extremely tricky, but what will complicate this? SRS is okay at this point in time, but if we come back for PCI then, or say...
That's why I'm telling you.
Yeah, so that is really going to complicate the issue. So
Okay.
there may be a school of thought looking at giving 25 to the whole brain and then a much higher dose to the gross lesion. That is a possible approach because, to reconcile doses at a later stage, post CTRT, if at all we're looking at a radical approach, will become much more difficult. But probably, treating the primary and the brain and then looking at how things go. And just 25 at the end of the day, I mean, it's still feasible to look at PCI at a later stage. Also, I think radiation oncologists today are more comfortable doing a fractionated SRT. This is nearly a 3 centimeter lesion. The larger the size, the more difficult it becomes in the long run to control ASA doses to the hippocampus, although this is closer to the dura. So probably maybe 3 fractions instead of just 1.
Okay.
That is something that I would consider. Yeah.
So what I did was I gave all these options to the patient and I confused him. And he said, "Doc, do whatever you want." So I said, "Okay, fine, let's get a surgery done." That's why I told you, Chandrakanth. I ultimately got convinced him for a surgery. And I told him, all your life, you will not know what is there over there. So get a surgery done.
Right.
So then he gets a surgery done. Then he comes to me and saying, should I be giving SRT to the brain lesion now or the PCI later? I said, shut up, it's a small cell lung cancer. I started with the chemotherapy. There was a partial response to treatment. And we did give PCI with some boost to the cavity over there. And the patient is continuing on atezo, on durvalumab right now. And the patient is doing absolutely fantastic. This patient has got 45 cycles of immunotherapy right now.
Wow.
So, with brain mets, we have actually got, Dr. Naomi, we had our data of around 40 patients. And our 18-month survival is actually 38%.
Wow.
It's 40 patients. There are 4 patients who are doing more than approximately a year or 2. So doing very, very well. And let's not overcomplicate more. This patient is doing absolutely fantastic. The RT to the lung also, we thought, then we'll say nothing is there. Let's just keep it over there. So I will just like to conclude. This is one of the heroes prior to, this thing was there. And this is how he married a very beautiful, most beautiful girl and the actress of this thing. And I'm sure after listening to Dr. Naomi, small cell is going to go the same way. And we'll have more sessions on small cells and less sessions on non-small cells now. So thank you. Thank you, everyone, for a wonderful discussion and being a sport. Thank you.
Thank you so much.
Okay.
Thank you, everyone. Thank you.
Take
So
care.
I think since I am the program director, I will like to thank Dr. Naomi. I like to thank all the panelists and the speakers for a wonderful discussion. And I really hope that small cell lung cancer comes out of here. and we see more small cell lung cancer sessions because it's more interesting, and we are going to see the revolution over there in small cell as we saw in non-small cells. With this, thank you.
And we want to see more articles of those published by you.
We
with
will
these
do that.
exceptional cases.
Thank you, thank you, thank you, thank you, Dr. Chandrakanth and Dr. Deepak for providing the first two cases, brilliant cases. Thank you.
Thank you, sir. Thank you.
Take care. Very nice seeing you all. Bye-bye. Take care.